we need to understand is how do we in intensive care take care of patients with cervical spine injury. Okay, let it be any that. What do you take care immediately and later on? Later on we know rehab and all comes in. But immediately as a doctor in the intensive care, what do you need to do? There's a lot of things that you need to do. First of all, what you must realize is C4 is the level. C4 level, agar there is a problem at C4 and above, the diaphragm is going to be injured. Okay, diaphragm is one of your main muscles of your body. One of the main muscles is diaphragm. Okay, and the diaphragm is the one that causes inspiration and expiration. But apart from that, you have an important muscle called accessory muscles of respiration. So whenever you need to do an extra activity, the accessory muscles of respiration come in place. Clear? Today, if I have secretion in my mouth and I want to take it out, I need my accessory muscles of respiration to work. Without my accessory muscles of respiration, if I have pain, I breathe faster because my accessory muscles of respiration starts working faster. If I have fever, my accessory muscles of respiration kick in place, but diaphragm doesn't really contribute as much as my accessory muscles do. We need those muscles at that moment. Diaphragm does contract, but we need those accessory muscles at that particular moment. Clear? Apart from that, there are two other very important muscles in our body called as intercostals and abdominal muscles. Similarly, the intercostals also play a very, very important role. The intercostal muscles, abdominal muscles are the ones that are innervated from T6 to L1. T6 to L1 is the one where you have abdominal expiratory muscles that come in place. Whereas the intercostals are specifically coming from T1 to T11. T1 to T11 is intercostals. Okay, the diaphragm is C5. Okay, C4. So if I were to categorize them, so I know my level of problems. Higher the problem, bigger the issue. Okay, so when I'm at C5, C4 up, okay, I'm losing my diaphragm. Just can you get another pen from there? In my room. C4 is diaphragm. C4 is diaphragm. Okay. T5, T1 to T11 becomes intercostals. T1 to T11 becomes intercostals. T1 to T11 becomes intercostals. Okay. Then the cervical cord relates to the accessory muscles. The whole cervical cord is the accessory muscles. And when you say T6 to L1, it is the abdominal expiratory muscles. Very important. Okay, very, very important. So this means to say most of your cervical spine patients will have affection of these. That means the internal intercostals, the intercostal muscles, the abdominal expiratory muscles, as well as the diaphragm is going to be under stress. Okay. Now, why is the diaphragm under stress? The diaphragm is very important for us. What does the diaphragm do? So, when you did chitin or physiology or for that matter anatomy, we learned of something called pump handle and bucket handle movement. What happens in inspiration? In inspiration, what happens is your diaphragm goes, so when you inspire something, it's going down. When it's going down, what is happening? The abdomen is holding where it is. When it's going down, my abdomen is not coming out. Okay, when it's going down, my diaphragm is going down, my abdomen is holding where it is, creating that pressure so that it goes back on top. You are creating, understanding what's happening? The diaphragm goes down, okay, the abdomen is holding where it is, and then because of the pressure, it comes back inside. So the more the diaphragm goes down, the better the pressure. The better the pressure. Clear on this till now? The more the diaphragm goes down. So the diaphragm is actually located in your body, which looks something like this, right? Like this is your body, and you have the diaphragm like this. Okay. So during your breath, your rib cage anterior posteriorly goes bigger and laterally goes bigger. The lateral movement of the diaphragm, lateral movement is also because of the diaphragm. The diaphragm over there actually moves the rib cage slightly, whereas the intercostals move it like this. So when we say adequate chest expansion, when I'm looking at it, I'm looking for lateral expansion and I'm looking for anterior posterior expansion. Am I clear till now? And then what happens is this diaphragm starts moving down. When the diaphragm moves down, this zone is called as the zone of apposition. Okay, this zone is called zone of apposition. Okay, that zone is called the zone of apposition. Okay, the more higher the zone of apposition, the more this rib cage will move outwards, which is important. The more higher the zone of apposition, the more the rib cage moves outwards. Itna samjha? Now what have we just now said? That when you have a person in inspiration and there is no pressure from down, the diaphragm will go even lower and lower and lower during you getting the point? It will go lower and lower and lower. It will not stand the way it is. So the zone of apposition reduces. Okay? If the zone of apposition reduces, the outward movement of the rib, that is not pretty okay. Clear on this till now? The other thing is when the diaphragm is moving up and down, what is happening in these cases? The external intercostals and external abdominal muscles are not working. So when that is not working, what is normally happening when you are coughing? You are pressing this down. The whole abdomen is pressing downwards. That's why you are doing that. So that external abdominal muscle is not really contracting, and that is the reason the cuff becomes weak. One of the reasons that the cuff becomes weak, the external intercostal. The intercostals, what do these do? The intercostals. The intercostals are the one that is responsible for holding the rib cage like that. Holding the anterior posterior movement that occurs is because the intercostals are working pretty well. Getting the point? Because intercostal stabilizes the rib cage, that is why the lungs per se are able to inflate like this. Getting the point? Now what is happening when all of these muscles are going down? When this is going down, rather than actually this movement happening like this and this going down, this is going up slightly, but the abdomen is also going up the other way around. When I am supposed to inspire, this abdomen is supposed to go inside because that's what my external intercostal are working. When I am inspiring. What is happening over here? At this moment, the abdomen is coming out. Why is the abdomen coming out? Because the external abdominal muscles which are responsible for that cough and all those things, that is not working. Because the splinting action is gone. Since the splinting action is gone, it is called as a paradoxical breathing, which is amplified. It is amplified when you are sitting. You getting the point? When you are sitting. So a spinal, it will be amplified when you are sitting. Because when you are sitting, what is happening otherwise? When you are sitting otherwise, your abdomen organs are not going down. They are not going inside. They are remaining where they are. Because of all these muscles that are there, the abdomen is actually sitting like that. But when you are actually having external abdominal muscles that are not working properly, what is going to happen? This will start going outwards and upwards, rather than actually sitting where it's supposed to be. So on my right, it is going outwards. You're getting the point? So this problem will be exacerbated when the person is having food also. So when the person is having food, what happens is, naturally there is food going inside, the abdomen will distend. So rather than the abdomen remaining where it is, हम लोग ऐसा नहीं होता, हम खाना खाया ऐसा पेट ऐसा ऊपर नहीं आता ना. But in those cases, because when they're having their food and all, the abdomen will become bigger, and accordingly the leg, this will also become bigger. Are you getting the point? So respiration becomes hampered. You getting the point? Clear on this? And that is amplified when the patient is actually in the sitting position. That's why a spinal cord injury patient will do better when the patient is actually lying down than when the patient is sitting up. Are you getting the point? तो अगर उसको wean करना हो मेरे को, तो I will keep the patient actually lying down because the mechanics of the diaphragm is better. Are you getting the point? Are you understanding this or not? Understanding this, right?
So not even 30 degrees.
No, flat, 10 se 15 degree. Not more than that, 10 degrees, maybe 15 degrees. Because when he's sitting up, what is happening is the diaphragm is actually down here. It is actually down here rather than actually having that good movement. It is actually down there. The abdomen is actually down there. It is split, not allowing that diaphragm to actually. Ideally, what should happen? It should go this much only. You understand? It should go this much only. Zone of apposition preserved रहना चाहिए. हाँ, ये क्या हो रहा है? ये एकदम ही लाउंज है. Zone of apposition ही नहीं है पेशेंट को. समझ में आ रहा है? वो organ पूरा नीचे चला गया rather than actually holding it where it is. And that's why you see it when the person is sleeping. You see ऐसा abdomen going up and down. You getting the point? So if you see the patient on top clearly, you will see that the lateral. When you tell him to take a deep breath, the lateral side does not move up. The anterior posterior mildly moves up, but the abdomen moves up more. That's what exactly you will see in that particular patient. समझ में आ रहा है? Have you understood? Understood how this diaphragm works and what is the zone of apposition here? Have you understood? Have you understood? So now, what is important for you to understand is, in quiet breathing, the diaphragm will somehow do okay. But the entire cycle is, what do you all do in the middle? You all have a sigh. You all have a secretion clearance. That is not there because his external abdominal muscles, his intercostals and axillary muscles are not working. You getting the point? So you will find him to be completely normal. But the cycle will be that he will be normal. After some time will develop atelectasis, then will develop an infection, and then will go into all kind of sepsis and infection and problems. Why? Because what you and me are doing, when we are quiet and sleeping, after some time we are we are swallowing, we are coughing, we are getting that big sigh that we are having. He's not having any of those. So as time goes, he will actually collapse his basal zones. Basal zone collapse will cause secretion retention because it's collapsed. That area is collapsed. That area is physically collapsed. तो वहाँ जो secretion से वो निकलने वाला है, because he does not have the capacity to cough and open that area up. He doesn't have the capacity to open that cough area up. Secretions will get pent up. Now these secretions being pent up, he cannot remove those secretions. That secretions will cause a culture medium. That culture medium will inculcate a bacteria, then will cause a pneumonia, and the whole cycle will be very dangerous. You're getting the point? You're getting the point? So patient is breathing well. That doesn't mean he's okay. He does not have others. So how do you monitor them? How do you monitor that this person is doing well or not? How do you monitor? Okay. So the first thing. So any ideas how do you monitor them? How do you monitor them? So there are a few important things that you need to look at in such patients. A, clinical. Clinically, you have to look whether there is adequate chest expansion first. When you say adequate chest expansion, I'm looking at the whole thorax going up, the whole thorax widening out, and at the same time the abdomen going inside. So the test actually says, keep your hand on the thorax, keep your hand on the abdomen, tell him to take a deep breath. If at deep breath, if he's taking deep breath and this is also going up, what does this indicate? That there is a paradoxical breathing. When you keep your hand like this and you tell him to breathe, okay, this is supposed to go up, this is supposed to go down, no? Or this is supposed to where it is. Correct? If you see that this is going up and this is also going up, means there is paradoxical breathing occurring. Okay, paradoxical breathing. So clinically you can see paradoxical breathing occurring. You may not be able to see the accessory muscles of respiration because it's not working. You may not be able to see the intercostals moving tremendously. You may not see all of these things, but you will see that. You're getting the point that there is a thorax breathing. Second thing is cough. Okay, now when we say, before we say even the cough, one of the things is inspiratory reserve. Okay, we just talked about clinically. Then the other thing we talk about is inspiratory reserve. Inspiratory reserve. As I told you, when the patient has got fever, when the patient has got pain, when the patient needs to cough, not for cough, he wants to take a deep breath, he can't do it. The inspiratory reserve is that. The inspiratory reserve is that. The inspiratory reserve is not there because intercostals are not okay. Because intercostals are not splinted enough. The rib cage that has to be stabilized and moved outwards won't ho raha. ठीक है? Because the diaphragm is not okay, the movement of this that is going on, zone of apposition is low, this is not going out. So the inspiratory reserve that he requires to do this procedure, to do this, is not there. Inspiratory reserve, especially when there is secretions, especially when there is a requirement to cough, all of these things he can't do. So tomorrow if he gets hypoxic, his nerves is telling please do, please do, please do, but he can't do. You understand? You can't do that. You understand? And we are monitoring saturation, we are not monitoring PaO2. So he may be dropping his oxygen, we don't know what's happening, but he still is not able to produce an inspiratory reserve. You're getting the point? Now the inspiratory reserve, how do you calculate, how do you figure out the inspiratory reserve? The answer is actually to do it with a machine called as respirometer. Okay, a vital capacity, a respirometer, this can actually figure out your inspiratory reserve. You understand? An inspiratory reserve, it is sometimes called as maximum inspiratory pressure, or it is also called as negative inspiratory force. Okay, it's called as maximum inspiratory pressure, or it is called as negative inspiratory force. When I say negative inspiratory force, this you can do on a ventilator. So if our ventilator, you see on an intubate patient who's ventilated, if you go to the GE ventilator and you press pulmonary mechanics, it's pulmonary mechanics, on mechanics, and you press in negative inspiratory force, what it does, it stops the inspiratory, it occludes the airway. When it occludes the airway, the patient takes a deep breath. When the patient takes a deep breath, how much amount of pressure is generated is what is negative inspiratory force. Clear on this? Understood negative inspiratory force? Or did you understand this negative inspiratory force? Again, I'll explain to you. Negative inspiratory force is there in most of your ventilators. If it's not there as a button, you can easily do it by actually just occluding the airway by doing an inspiratory hold. Okay, all you have to do is the pressure waveform. You have to see the pressure waveform. The pressure waveform is there, pressure waveform. Put the patient on spontaneous breath and tell the patient to take a deep breath. When he takes a deep breath, what is going to, and at that time press inspiratory hold. Inspiratory hold is there on all buttons because you do plateau pressure. Plateau pressure is done by doing inspiratory hold. So inspiratory hold is something that is there in all ventilators. So press inspiratory hold and tell the patient to take a deep breath. In some other ventilators, we already have a button called as NIF. What does NIF do? You press NIF. The moment you press NIF, there is an inspiratory hold that occurs. The ventilator occludes the airway. When it occludes the airway, The patient takes a deep breath, he's not getting air, but he's generating a pressure. That flow change is actually related as a pressure, and that is called as negative inspiratory force. Okay, what you must understand is normally if you have minus 30, you are doing pretty well. Negative inspiratory force. You're doing minus 30, you're doing pretty well. Okay, minus 20, you're not started doing, you started getting a problem. Minus 10 is really poor. Negative inspiratory force. Clear on this? Minus 30 is very good. People generate 60 and 50 and 70 and all. Negative inspiratory force. But minus 30 is good. Minus 20 is started getting problematic. And minus 10 is really, really bad. Okay, negative inspiratory force. The same thing when you do with a machine, with a respirometer. It is called as maximum inspiratory pressure. The same thing is done. It is a machine. It is a machine which has a tube, a small tube. You just occlude the inspiratory the chamber, and you tell the patient to breathe. On the machine it comes कि कौन सा कितना negative inspiratory pressure है. So at that time the only difference is you might find this in respiratory physiology to be not in minuses. They'll say 30, they'll say 40, they'll say 50. That's the difference. When you say MIP, so you should not get confused. Sometimes you are reading articles, it might say MIP is 40. It's not plus 40. This is a term you use in physiology, in respiratory physiology. When you say maximum inspiratory pressure, it is just giving you pressure in 40, but either it means the same thing only as negative inspiratory force. Clear on that? It's only the device monitors a pressure. That's why it tells you 40 pressure. Maximum inspiratory pressure. Clear on this? Clear? So negative inspiratory force and maximum inspiratory pressure. These are two things that we need to understand in these cases. Maximum inspiratory pressure. How you can also understand this inspiratory reserve. And when you do this, it's not this way that you tell the person to just breathe normally. You have to ensure that coaching is very important when you do this test. First of all, if you want to do this test in your patient, it has to be done at the same time of the day, at the same position, and after coaching the patient. And what do you coach the patient? So is very reserve. So how do we do it? If we have to do it in our cases, how do we do it? Inspiratory reserve. So you have to coach the patient. You have to coach the patient. What do you coach the patient? First of all, keep the patient in the same position. Okay. You can actually figure out whether there's a problem first by doing it in supine and then doing it in propped up. What did you see? Supine and propped up.
There was no changes.
No change. So what happens usually in cases who are very badly affected, in supine, if you look at very carefully, in supine the patient will have better inspiratory reserve. In propped up, the inspiratory reserve will not be very good. Why is that so? No? Zone of apposition. No? Zone of apposition goes lower down. Zone becomes smaller. Since the zone of apposition becomes smaller, the inspiratory force reduces. समझ में आ रहा है? So ideally, when you are doing inspiratory force, you put the patient, do the spirometer, use the spirometer. On the spirometer, just put, there are markings on it, but you can put additional markings. You can put additional markings. एक छोटा सा रोलर लगा के additional markings डाल देने का उसमें. And then tell the patient, you first, how do you do it? You keep the patient in first propped up position, and then you exhale completely out, and then inhale. Take a very big deep breath. So that number that comes in, that is what you're going to find out. The ball how much upar chala gaya, that you make a visual note of it. Then you make the patient supine again and do the same thing in supine. Okay, you'll see it. So there will be a difference. Once there's a difference in the supine and the propped up position, we'll go and do it in some time. If you can go and do it, go and do it. In supine and propped up position, what does it indicate? That definitely the zone of apposition is not okay. That's why the inspiratory reserve volume is low. समझ में आ रहा है? समझ में आ रहा है क्या करना? What will you do?
Like checking both positions.
No. First, what do you do? The simple respirometer जो हमारे incenter spirometer है, on the incenter spirometer you will make those markings. You will make those. It's very essential to make those markings. Without making markings वो नहीं काम होता है. 1 centimeter का marking करने का उसमें. Okay. Then what do you do?
We'll just check in both positions.
No, not check. You have to coach. So this is wrong. What he says is completely wrong. You have to coach the patient. So what do you tell the patient?
We ask the patient to first exhale completely and then take deep inspiration.
After occluding the air, after putting his lips across it. Clear?
Yes.
So you have to coach. If you don't coach, you are not getting, because this is completely patient dependent. It's completely patient dependent. If you say chalo fuk maro, it doesn't make sense. You have to coach the patient, to tell the patient very clearly that आपको जितना लंबा सांस लेना उतना लंबा सांस पहले निकालना है और फिर जितना हो सके उतना लंबा श्वास लेना है. This is what you're supposed to tell the patient. If you don't tell this, means you're doing wrong. ठीक है? So what are you going to do? You're going to tell the patient in that position to first exhale out maximum and then take a deep breath and then notice कितना level पे आ रहा है. So that will give you a position in the supine and give you in propped up. What am I expecting? I am expecting कि propped up में मेरा वो inspiratory reserve कम रहे. I'm expecting that. Whereas in supine, my this will be better. समझ में आ रहा है? You getting the point? So that is what you will do for inspiratory reserve volume. That is if you don't have the meter called as the spirometer. If you have another inspiratory reserve volume on a machine, you can easily do it by just telling him to stop it and you occlude one part. When you occlude one part, you see the pressure. That's what occurs. Clear on this? So when you do it with the machine, it is called maximum inspiratory pressure. When you do it on the ventilator, it is called as negative inspiratory force. When you do negative inspiratory force, what is happening? The ventilator is occluding the airway and the pressure is getting you're finding out on the ventilator. To do this, you have to coach the patient, and every time you do it, it has to be at the same time of the day in the same position. Not after physiotherapy, not before physiotherapy, not after food, not before food. It has to be at the same time. It has to be at the same time that you're going to do that. Okay, clear on this? It has to be at the same time. So that's very important to monitor it every single day. Inspiratory reserve volume. It gives you an idea what is happening. So today, if it was 5 points, now it has come to 4 points. It's come to 3. No, the inspiratory reserve volume is going down. Why is that important? Because if this was low, the next step that is going to happen is the basal zones of the lungs are going to be collapsed. If this is low, the basal zone of the lungs are going to be collapsed. It's called atelectasis. That is going to occur. And why is it going to occur? Because he does not have the psi function. This patient does not have the psi function, cannot remove secretions. So what is happening? The basal zone will cause basal atelectasis. Patient will not show problem. Diaphragm will be normal. When you do ultrasound of the diaphragm will be normal. You're getting the point. But the patient will develop atelectasis. Exactly what's happened there. It's exactly what has happened there. If you look at it, that patient on top, it is exactly what has happened over there. What has happened? His diaphragm is moving well. It is 2.5, 2.6. His diaphragm is moving well. Quiet breathing is doing well. What has happened to him? He has developed bilateral atelectasis. Bilateral, basic, large atelectasis. What we had to do? We had to actually put him on NIV. Are you getting the point? This is exactly what we've done over there. It is bilateral. So, as a doctor on the in the ICU, you're going to check the inspiratory reserve volume. The other thing you check in such cases is usually the vital capacity. This again done by a respirometer. If you don't have that particular meter, you use the vital capacity of the endotracheal tube if there is a patient on the ventilator. On the ventilator, again there is a button called as vital capacity. Many ventilators have it. You press it, tell the patient to take deep breath in and out, in and out, in and out, and it checks the vital capacity. The vital capacity has to be minimum somewhere around 15 to 20 ml per kilogram. This has to be the number, 15 to 20 ml per kilogram. If the vital capacity is of this level, then the chances of the person having inspiratory reserve volume related problems are less likely. Are they less likely? Inspiratory reserve volume समझ में आ गया? The vital capacity समझ में आ गया? Now the other thing that you check in these cases is called as maximum expiratory pressure. Now this is very essential. Maximum expiratory pressure is cough. Is actually your cough. How much you can cough. Now this can be done by using a meter called as peak expiratory flow rate also. Okay, peak expiratory flow rate. Again you have to coach the patient. You have to tell the patient that आपको जोर से अंदर सांस खींचना है और फिर जोर से आपको फूंक मारना है उसके अंदर. That is called peak expiratory flow, maximum expiratory pressure. You and me have a maximum expiratory pressure 260 liters per minute and up. We have 260 liters and up, more than 260 liters and up. Liters per minute. That's the flow that we can generate. We generate 260 liters of flow per minute, and that's what we generate. And that is responsible for getting that cough to be so good that it propels out the mucus, it dislodges the mucus from the wall, and it tries to get it to the mouth. You are doing three things. Now, when you're coughing, what are you doing? Just you're generating a inertial pressure, then you're creating a propulsive pressure, and then you're developing a flow. There are three things happening in a cough. Correct? You're first developing an inertial pressure. That's what your diaphragm, your intercostals are doing. Second thing, what you're doing, you're developing a propulsion, and third, you're developing a superflow, which actually expels whatever's inside. Clear? So that's what there are three mechanisms that are occurring in a cough. So in that cough, we are looking at all the three mechanisms in this case are not okay. All the three mechanisms in this case are not okay. Diaphragm is not moving, so going down is not okay. And it's not going properly. External intercostal is not working, so the external pressure that is responsible for creating the propulsive mechanism, that is not there. Get the point? So all the mechanisms over here are not working. That's why the maximum expiratory pressure in such cases to measure will be less than 160, 120, 100. If you measure. Now the issue is we don't have a measurement device. So if you have a measurement device, nothing like it. But if you don't have it, what do? Every day you come and you ask the patient, खांसी करके दिखाओ. खांसी करने पे you will get sound, but you will not get air. What you require? Air. You require air to come out. You getting the point? Huh? Oh, आवाज नहीं है. We want the air to come out. समझ में आ रहा है? Air. You clear what I'm saying? ऐसा करके कोई मतलब नहीं है. It is the air that has to come out. Got it? So you have to qualitatively understand. Okay, this is a violent cough or not. Because what you must understand is, if there is no cough, the secretions are not going to come out. And the secretions remaining in the airway means that secretion get more and more dried up. The more drier it gets, the more it gets stuck to the airway, the lesser the chances of it to be propulsed out because there is no flow. You get the point? There is no flow. Getting the point? There is no flow. Since there is no flow, the secretions remain at the airway. Dhire target it gets into the lungs and then causes a pneumonia over there. Clear? So we have a problem. So that patient on top who is basically having atelectasis, the next step is what? Pneumonia. You understand? The next step is pneumonia. Because unless we get off that atelectasis, we are really stuck. समझ में आ रहा है? Really stuck. Clear this? वो pneumonia होएगा, and because he's got, you and me, we have pneumonia, we will probably cough, we will remove it out. That's what our defense mechanism is. We cough. That's why patients who come in with pneumonia have got cough, product of sputum. These people will not be able to do that because they just can't cough. You get the point? So the cycle becomes so bad that the patient gets intubated, ventilated, and just for that pneumonia needs to be done, many more things to be done. Tracheostomy, secretion training, God knows. Okay. So then what do you do in these cases? How do you ensure that these patients cough well? Now initially we talked about inspiration. Now how do you, so for those patients who are in inspiration, they will have to be, we have to wait, watch, ensure that the patient is in supine position, don't keep it in propped up position as much as possible. You know, normal tendency for all of you is keep the patient propped up. But in this case, if you keep the patient propped up, what is going to happen? The inspiratory reserve will go down. Inspiratory reserve will go down because what is going to happen in the propped up position? The zone of apposition is reducing, and hence the rib movement, rib cage movement, anterior posterior and lateral, that reduces. Since that reduces, the reserve volume which was there, that is also gone. Are you getting the point? So such patients are even fed in the 10 degrees, 15 degrees, because what happens is you feed them, again the problem will happen. Rather than it being holding where it is, the food where holding it is, it will start descending downwards because the abdominal muscles are not working. You get it? So you will feed them at 15 degrees rather than propped up position. You getting the point? This is a problem that's occurring with this. So now, if the patient does not have cough, what do you do? So you do cough assist. So if you see the physiotherapist, you see what they do in such cases. What do they do? Anyone seen what they're doing on top? Okay. So what they will be doing? They will be doing something called as cough assist. What they do in these cases, you tell the patient to take a deep breath and cough. When they are coughing, they press with their abdomen. Okay, they press the abdomen. So the physiotherapist keeps the hand on the abdomen. Okay, tells the patient to take a deep breath, and when the patient is coughing, it presses the abdomen. So it's creating that force which otherwise is not there. They are creating a force which is otherwise not there. So that is called cough assist. That is called cough assist. So cough assist. Cough assist is done as a physiotherapy. So when you are also taking your lunch, you can खांसी करो, press करो. So even if तुम क्या कर रहे हो, खांसी करके press करके भी कर रहे हो, तो secretions which are lying somewhere here will be propulsed upwards. They will propulse upwards. When it comes upwards, at least he can take it to his mouth. He cannot take it out otherwise. नहीं आने वाला खाना. समझ रहे हो? नहीं आने वाला. It is not possible because he does not have that flow. He does not have that flow, that effort to get that out. So you do cough assist. So in your round, when you have a patient like this, you normally do. Let's say I did it. Yesterday when I was taking the round, I did cough assist yesterday. Okay. So when you do a cough assist, what do? You press the abdomen. When you tell the patient to take a cough, you press it. You can hear then कि secretions ऊपर जा रहा है. You can hear it. If you hear it, you start doing suctioning. You getting the point? समझ में आ रहा है? Cough assist. There are devices. It's called manual. That's called insufflation, exsufflation devices. There are devices that are available called as insufflation, exsufflation, cough assist device, where they have cycles of insufflation, cycles of exsufflation. Okay, insufflation, exsufflation device. These are device patients. These are also available by putting some band here like this, and that gives you cough assist all the time. And there is devices you push the endotracheal tube that also causes insufflation, exsufflation. There are devices available abroad. In even India, there would be. I mean, some of the major hospitals we still have insufflation and exsufflation devices. Okay. Second. Third, in these cases, if you want to do a cough assist and these things are not working, is you put an abdominal binder. So when you put an abdominal binder, what is happening? The abdomen is no longer going this way. The abdomen is remaining where it is. Since the abdomen is not going upwards, the diaphragm apposition remains the same. Zone of apposition remains the same. You getting the point? Since the zone of apposition remains the same that we talked about, the diaphragm can still develop that kind of force. Some amount of force it can still develop. So an abdominal binder is used in such cases when you see that the cough assist is just not improving. I mean, cough is not improving at all. You getting the point? Huh? The other thing is to monitor the cough by using a blotting paper test. Now, what is the blotting paper test? You keep the test, you keep the blotting paper, take number of blotting papers, take 7-8 blotting papers in your hand. Huh? First, keep it nearby, and tell a cough. When he coughs, you'll see some dots, some secretions coming in. Then go farther, then go farther, then go farther till it never comes. So you know at this level it's not coming. Then you serially follow that. You keep the blotting. You understanding? You tell him you keep it over there. And next day again you come and check in the same place. If in the same place it's not coming, means obviously that force is coming down. That's called blotting paper test. That's called blotting paper test. There's also candle blowing test. We don't do that, but that's also part of this. Okay? So but blotting paper test is simple to do. Clear? So cough assist you have understood. Now the important thing over here is, now you have understood that secretions cannot come out. In such patients, secretions cannot come out. That's the importance of postural drainage. This is one of the very important parts where postural drainage becomes very, very important. And as a bedside doctor, you should be able to tell them, or the physiotherapist, or the nurse, or yourself, which position I should give these patients. Okay, so if I find that the posterior part of the lungs are, or one side of the lung is kind of getting infected, I will tell them what? Keep that lung down or up? Keep that lung up. Now you can imagine how difficult it is to keep that lung up, because patient has to be log rolled. Then physiotherapy has to be done. You're getting the point how difficult it becomes. It becomes extremely difficult to actually do postural drainage in these patients. But postural drainage has got very important significance over here. Very, very important significance. Why is it important significance? Because you and me, we will cough it out. They cannot. So the only way we can open up a lung that has collapsed is by postural drainage in these cases. It's very difficult otherwise. Drainage and physiotherapy, that's the only way you can do this. You cannot do it in a otherwise. Rest everybody will cough, take it up and you will suck. Okay, in this case, you just can't do that. You just can't do that. You getting the point? Clear? So, say you have a patient, so you've understood about inspiratory reserve, you've understood about vital capacity, you have understood about negative inspiratory force, maximum expiratory pressure, how to use the respirometer, how to use the incentive spirometer in such cases. You've understood all of these things, correct? So this is how you take care of patients in the respiratory system. But importantly, if you want to wean these patients off, you're going to do all of these things when you're weaning. Negative inspiratory force, maximum pressure, diaphragm you're going to see every time. Why are we looking at the diaphragm? What are we going to look at the diaphragm?
To see the worsening.
So what are we going to see? So every day I will see the excursion. Excursion देखना ही है मुझे. Excursion देखना ही है, and I will trend it. Same position, diaphragm. I will see the diaphragmatic excursion. We now know how to do diaphragmatic excursion. You see that down curve, you put a line, and you see where the diaphragm, how much it is moving. So I'll keep looking at it in quiet respiration. In quiet respiration, I'll do that. I will also do it in maximum inspiration. In this case, I'll do it for maximum inspiration, because when I'm doing maximum inspiration, I'll see the maximum rise of the diaphragm, maximum movement of the diaphragm. So in this case, I will look for it quiet respiration. I'll also use it for maximum inspiratory pressure that I can develop on the diaphragm, with the diaphragm. Second, third, what am I looking for? I'm looking for the total zone of apposition. Can I see a longer zone of apposition? Can I see a smaller zone of apposition? I can see that. I can see thickening fraction of the diaphragm. I can see thickening fraction of the diaphragm. Third. Fourth thing, what do? I look in that angle for a pneumonia, for an atelectasis, because that is where my atelectasis comes. So the ultrasound monitoring of a patient who is having cervical spine problem becomes very, very essential, because you will pick up that atelectasis quickly and you will aggressively do things more. What aggressively you can do? You may want to put NIV, you may want to put cough assist, you may want to do many other things that are there. क्या करना है? So okay, so now you have a patient on the ventilator. Now this is all patients who are not ventilated. Now patient on the ventilator, and you are thinking of weaning this patient. If there is a high cervical spine, somewhere where the diaphragm is gone, there is no point of weaning only. Because if it's a high cervical spine, तुम उसको wean करके कोई problem भी create करने वाले हो, because वो wean नहीं होने वाला. उसका diaphragmatic excursion less than 0.8 है, तो वो काम नहीं करेगा. वो it is not going to work. So you have to wait for 4 to 6 weeks. Now why do you wait for 4 to 6 weeks? You wait for 4 to 6 weeks because somewhere at 4 to 6 weeks, all these intercostals will get fibrosed. So automatically it will start splinting the lungs. Automatically it will splint the lungs. The diaphragm will be splinted because it gets fibrosed. The entire area, because it's disused, it just gets fibrosed. So when it gets when the cartilages, when the muscles around it starts, the fibers starting getting fibrosed at 4 to 6 weeks. Maybe you may be able to try to wean your patient if there is some diaphragmatic force. If it's less than 0.8, definitely it's a no-no. But say you have 1, to 1 or 1.2, which is like very, very borderline. If it's very, very borderline 1 or 1.2, what I can do? I can still wait for 4 weeks, wait for these intercostal muscles to get a little bit more stabilized. When this is stabilized and it's no longer working, it's just getting fibrosed hard, there is a possibility, that this action that we have can be done by the diaphragm with that 1.2 force. But it cannot do it otherwise. Otherwise it keep collapsing. Paradoxical respiration will keep on occurring. You get the point? If it stops collapsing, remains where it is, then maybe in the supine position where this diaphragmatic mechanics is the maximum, I may be able to wean off my patient. In the supine position, now you understand why. In the supine position, why the diaphragmatic maximum action will be. And now you know when to start weaning. So starting to wean at 1 week is rubbish in such cases. Okay, you cannot do that because splinting hasn't occurred. You get the point? You start weaning at somewhere later on. This is specifically for those patients who got high cervical injury, where the diaphragm is gone, C1, C2 level. If you want to try some weaning also, and there is some diaphragmatic movement that is there, maybe 1 centimeter or maybe 0.8 or 0.9 or something like that. Less than 0.8, it is highly impossible to wean off these patients. Less than 0.8, highly impossible. But the problems remain of suctioning, of crepitations, of atelectasis, that will remain. Why that will remain? Because obviously it doesn't have the inspiratory reserve volume, nor do they have the maximum expiratory pressure. Clear on this? They cannot develop that vital capacity. Looking at an ABG is rubbish. Looking at ABG is completely rubbish. Why is it rubbish? Because an ABG worsening is the last thing that is going to happen. It is the last thing that is going to happen. Okay, where ABG worsening. It is just prior to arrest that the ABG is showing 120 PCO2. Are you getting the point? That means you missed out the whole thing only. So, if you are going to say I'm going to follow ABG daily, means it is not the right thing to do. You are getting the point. It is not the right thing to do, because what is going to happen is, why will I follow the ABG? I will follow it to look at the lactates, whether the patient is having acidosis, because acidosis will not allow the patient to breathe fast. Will not allow the patient to get that big if the patient getting septic, he's getting fever, he can't do the way like all of us breathe. He can't manage. If he's getting septic, he can't manage. I'm not doing it for PCO2. If I'm doing it for PCO2 means I don't want to monitor ISO. You getting the point? Because that is the final thing that happens. When the PCO2 going up, that is the last thing that will occur. Are you getting the point? So the ABG for PCO2 doesn't make sense. It's the last thing that will occur. But I will do the ABG for a lot of other things because I want to pick up these problems much earlier than an ABG. Are you getting the point? समझ में आ रहा है क्या कर रहा हूँ मैं?
So how frequent they need to do the ABG, because it's just for the lactate and metabolic?
No, that if you suspect. Now see, if I have a patient that has developed an atelectasis, now having a fever, I want to really know what the lactate, what the acidosis is. I'll probably do it. It's clinical, no, completely clinical. There's no number. There's no number at it what I'm going to do. But there is a clear trending on this, on all of these things. Like for example, if you don't know if you cannot do the incentives parameter, you can't do the inspiratory reserve volume, I'll do a single breath count. A single breath count is also inspiratory reserve volume. So when I take a amount of breath and say 1, 2, 3, 4 till I can do, that a single breath count is a part of the inspiratory reserve volume. Are you getting the point? So I can do many other things, but I have to do it end on end, same position, same time, again and again. That is when you will understand what is to be done. So I will monitor the diaphragm to the ultrasound, I will monitor single breath count, I will do incentives parameter related, I will look at cough, I will look at secretion drainage, I will look at ultrasound to understand whether there is any atelectasis, and I will look at whether the chest expansion clinically is good enough that it shows pump handle as well as bucket handle movement, and I will look at other signs of infection, fever, and for that matter acidotic conditions. Otherwise, without that, I can't monitor these patients. So, we understood how to monitor patients with cervical spine problems in the ICU. Cough assist, you have understood?
Yes.
ठीक है.